Commissioner, are we ready? We're going to wait a little long as people are logging in.
No, time now is 1:02. We're ready to begin.
Good afternoon and happy Friday. I'd like to thank you for joining us today for our mandatory training. I'm Ira Farley, and I'll be your host during this session. For our technical support, Kenesha Busby will be assisting. Before we get started, we want to check in and provide a few reminders. This session is being recorded. Better audio quality, please remember to mute your mics on your computer or phone when you are not speaking. Handouts for the training have been distributed to registered participants before the training. If you've not received them or in need of the handouts, please email mchtraining@health.ok.gov and they will be sent to you. During the session, feel free to ask questions during each presentation at the discretion of the presenter. At that time, if you can unmute your mics. If this is not an option, we also have a chat feature within the meeting application. Feel free to use this option during each presentation as questions arise. Each presenter will allocate time during the presentation to address those. As a reminder, attendees are to complete verification of attendance by way of the individual sign-in form located on SharePoint, or for the contract agencies, Tulsa Health Department, Oklahoma Health Department, and Youth Services of Tulsa, you will have your own hyperlink to access. This will enable DNMs to easily verify your attendance for this Title 10 mandatory training. Commissioner, I have a question. Well, there's also a QR code that has been sent. Commissioner, do you have any comments regarding sign-in sheets?
I do not. Just as a huge reminder, we do want to use this recording to disseminate. So please be mindful of your unmuted mics. And also, too, if you look in the chat, there is a form that everyone can use to sign in.
Yes, and also, as possible, those that are attending the live meeting now, if you can do your sign-in sheet during this session, the earlier the better, because I get the data directly like I've never been able to do before, and I can then give your district nurse managers the information at the end of the meeting so they know who's been in attendance. Okay. For this afternoon, we would like to thank Jennifer Hahn and Jolene Johnson. They'll be our first presenters. Jennifer is the current director in records and community health systems here at the Oklahoma Central Office, the OSDH Central Office. She will bring us information on FOSIS, and billing changes to our clinics. The next presenter is Jolene Johnson. Jolene serves as the Revenue Manager, Records and Community Health Systems here at OSDH Central Office. She will capture information on our contractors and revenue from our services. Now we will hear from Jennifer and Jolene.
Welcome, and thank you for taking the time out of their day to hear what Jennifer and I have to say. I think I am waiting for Kamisha to pull up my PowerPoint because we're having some connection difficulty here at in El Reno today. Thank you. All right, and so I am working on from my cell phone, so I'm going to do my very, very best to multitask here, and hopefully I can get through this without annoying anyone here. Okay, and Ira, you can hear me okay?
Absolutely.
All right, yes. Thank you. All right, then I'm going to get started. So again, I'm Jolynn Johnson, and I'm with Community Health, and I have Jennifer Hahn here with me. She's going to follow right behind me with some fantabulous information for you. And so I'm going to get started with the things I'm going to cover today. I'm going to talk to you a little bit about insurance contracts, claim denials and rejections, revenue billing reports, and billing office contacts. So for insurance contracts, these are the payers that OSCH is contracted with. There's Aetna, Blue Cross, Community Care, Health Choice, Medica, Oklahoma Complete Health, Oklahoma Medicaid.
Excuse me, may I interrupt? Yeah. I'm sorry.
Yeah,
I'm getting some feedback from people saying they can't hear anything. One just said sound is good. So maybe for a moment, okay, one person responded back, sound is good. Someone else said they couldn't hear anything. So I'm not sure. Tamisha, any quick comments regarding that?
The quality of sound is good on this end and on the recording. So I would try to check your personal network to see if the sound went out, but I can hear it fine on my computer, but also to the recording.
And I will also make the effort, and I'll talk a little more directly into my speaker on my phone. Thank you.
Okay, the person said I had to log out and come back to here. Okay.
Yeah, we're
so
good.
People are
we're
figuring
good.
things out.
Go ahead. We're good. Go ahead, Jolynn.
Okay, thank you. So again, payer contracts, the OSCH, we are contracted with Aetna, Blue Cross, Community Care, Health Choice, Medica, Oklahoma Complete Health, Oklahoma Medicaid, Medicare, and we are a mass immunizer, meaning that we only will be paid for flu, pneumonia, and COVID vaccines, TRICARE. So it's a small list of who we're contracted with as far as us being in network, but these contracted payers represent approximately 90% of our claims volume, and we do bill for more than 170 plans. So those represent about 10%. So, and we are contracted with the ones that we are, seeing the most, at least. And so contract information by payer, I thought I'd take a little bit of time to share this information. This is something I've not talked about before, but I think it's important to kind of understand how we're contracted by payer. So we are contracted as a group provider under our public health clinic NPI with these payers. The fun thing about this is it's a pretty straightforward contract, and we don't have to do any credentialing per se, or at least a lot of credentialing. We might have to have one or two folks, maybe our medical officer credentialed or something like that. But as far as having the masses or all the mid to high level providers having to go through a credentialing or a provider agreement process, these payers have kind of given us a pass on that. And so this is really pretty awesome. It makes it easy for me because me, myself, and I right now is the only one dealing with contracts. So for Blue Cross, our district mobile units, Health Choice, Medica, Medicare, and Oklahoma Complete Health, we kind of got to push the easy button on contracting, at least for right now. Now, for the ones that are a little more complex, and I have to just take a moment to say I'm a little bit behind on dotting my I's and crossing my T's with some of these payers, except for Medicaid. That's our highest volume payer, so that's the one I can't let go too long. We have to make sure we're on it. But these are the payers that OSCH is contracted as a group provider, but there are some fairly involved credentialing or application processes that has to be done to maintain the continuity and stay in with our contract agreement. So Community Care, they have kind of looked the other way with us. I am thankful for that because I've not had a lot of time, but I will be working with community care and the TRICARE contracts a little more closely to make sure we're all caught up and everything's good to go in a nice, neat bow. But community care is a little bit different from the respect that they require, or they only have like certain coverage areas. And so if you're a provider in one of their coverage areas, you're the only, you're the one that has to be credentialed or should be credentialed. And I need to let them know that. I don't even know who my contact person over there is anymore. COVID just kind of threw a wrench in a lot of stuff. And I was easily blame COVID. But there's just a lot of things going on. But I will take the time. You might hear from me if you happen to be in one of the coverage areas for community care. You may be hearing from me, and I'll just rattle off a few of the coverage areas for community care. I may not get all of them, but I think I have the majority of them listed here. Are Cherokee County, Cleveland, Okmulgee, Osage, Mays, Muskogee, Payne, Pawnee, Rogers, Wagner, and Washington. Again, there may be a few more. And I know we have a lot of new providers since the last time I, shook hands with anybody at community care and got a, hey, what's up? What's new? What are some changes with your providers? I haven't heard from anyone in a while, but I will make that connection. And so you will be hearing from me if you're in any of those counties or the coverage areas, if I forgot to mention one. For Medicaid, we're as good as we can possibly be as far as if you're have had and currently have a contract with Medicaid. I think everybody's for the most part pretty good. We have some new providers, like new nurse practitioners that may or may not have contacted me, but in the event that you have not, please do, and let's make sure your contract's good to go. Just having a contract with Medicaid isn't necessarily enough for OSCH to get paid. If you're just new on board, we need to make sure that it's the correct contract type. We also need to make sure that you're associated with all of the Medicaid providers, because we bill in a box with Medicaid. We have a family planning NPI, we have a maternity NPI, a EPSTT NPI, and we have 10 individual NPIs, or well, one NPI, but anyway, we have mobile unit contracts as well. So depending on what you're doing and what programs you're working with, we may need to get you associated. So just be mindful of that. With TRICARE, I think it's a pretty much across the board. It's a fairly simple thing. It's just a provider agreement. And I need to revisit that the first of the year or as soon as I can and get with everyone that maybe that we do not have a provider agreement in place with TRICARE. So for our nurse practitioners and Medicaid contracts, this is our largest payer. So this is, the bird that gets the worm, if you will. And so these contracts must be renewed every 4 years. Luckily for nurse practitioners, and just renewed like in 2021. And so the next renewal date is November 30th of 20. Yeah. It's getting close to
Jolene.
If we slow.
Jolene, I think your phone's cutting out again.
Okay, can you hear me now?
Yes, I can hear you now.
Oh, so about nurse practitioners and Medicaid contracts. So we have the new PRNs. All is that if you're new to the agency and you haven't talked to me or sent me an email or gave me a call or whatever, please do take that opportunity to let me know who you are, introduce yourself, and then you can have a conversation and make sure that you're associated and contracted, especially with our Medicaid. This is how you me contact our billing group email, which is listed here on the line. It's honored daily, or you can talk a little bit about medical claim denials and rejections. Unfortunately, just due lack of resources, here again, I say this almost every year, and it is what it is. We're doing some wonderful things, though. I can just definitely attest to that. But here's some common denials and rejections. So eligibility is the first one listed, just for the fact that it is probably the most prevalent reason for denial or a claim being rejected. And so what we're doing right now, we're doing some great work. We're able to go face to face. We've done probably about half of the districts at this point. We've gone in person. We're doing some clerical training. Where we're having conversations. I'm giving them some tools for them to help them collect the proper information, so that we can hopefully make sure that we have the proper things in the focus insurance module that would prevent a claim to deny, such as if there's, like, for Medicaid especially, we have the ability to verify we have the ability to verify eligibility every single visit. So we're just saying, just as a reminder, if you've never heard this before, right? Let's check eligibility. This is our largest payer. If we don't get paid by Medicaid for these folks, we're likely not going to get paid at all, right? So we're just, it's like a couple hour presentation with exercises. It's wonderful. And there's another reason would be like patient name or the relationship to policyholder, the member ID, or maybe there's just not coverage. But for the most part, eligibility, all of our clerical staff that are out there interfacing with the clients, they have a golden opportunity to get the information that's needed to hopefully reduce the number of eligibility denials and rejections. The other thing that they can directly affect is, just asking some questions. Now that they have a little bit of education, at least half of them, we've not been out there in a training sorts for several years, and a lot of the clerical staff have never heard some of these things, and I'm learning things as well. So I am very appreciative. So the other thing that can happen is, the client walks up, they say they have Medicaid, they verify the Medicaid. Maybe they don't know that there's a TPL tab. They can see if they have another insurance on file, because Medicaid is always a payer of last resort. In that case, this prompts them to say, Jane, do you have Medicaid? Says you have Blue Cross and Blue Shield. Let's get that information. Do you have it, or do you not? And go from there. And so the list goes a little bit deeper. I'll stop there. But these are some things that we're doing to maximize our revenue. So we're trying to get paid by payers and not beat our clients up for payments, right? So for that, we have the patient responsibility section, which, these are things that right now we're not, running down the street trying to collect money from our clients. We're trying to get it from their insurance if they have some insurance.
Hello, Julian. I think your call completely, your sound went completely out. We can't hear anything you're saying at this point.
Okay, now can you hear me?
Yes, we can.
It self-muted. I haven't touched it. I'm
not sure. I haven't either. So I'm hoping no one accidentally touched it, but we can hear you good now.
Okay. Let's just try this again. Can you tell me about can anyone tell me about what slide they quit hearing me on?
So we're currently on the common denials and rejections. You talked about the patient responsibility, and that's the last part that we heard.
Okay, perfect. That's not too bad. All right, and pretty close. So patient responsibility, these are just things that are things. If a client has an agreement with their plan that they have to meet a deductible, co-insurance, and services that aren't covered, and we're out of network for majority of the payer. Well, I say the majority of the 170 something payers, but for the most part, like I said, those out of networks are going to be like that 10%, right, of our private insurance clients. But these are patient responsibilities. And the only exception that, to a patient responsibility, at least for right now, we're only charging for those that are, family planning clients that are cash pay or uninsured that might have a sliding fee scale applied. And also those anyone that is receiving any locally purchased vaccines, they're going to get charges for those. But for the most part, we're not beating up our clients to get paid. We are trying to get paid by their insurance plan if they have any coverage at all. So those are things that we're talking about with clerical staff as well. So just putting that out there. Then we have system issues. And so we have a long laundry list of things. We know there are things that are wrong. Our system isn't perfect, but let me tell you, it's better than manually billing all of our stuff like we used to. We do have some duplicate claims that are included in some of my claim counts you're going to see here momentarily. These are things that I think we have a hiccup in our system. We don't really know exactly 100% why we get a whole bunch of duplicate claims. The other reason a duplicate claim can occur is when we have to truly make some changes in the PAR module. We hit edit and save, and it submits another claim because we're changing maybe a unit, a service, a provider potentially. So it's going to happen. The good news, duplicate claims typically will not pay us twice or multiple times. So we have incidentals also that happen because when we bill a procedure that's considered primary to some of the ancillary things that we do, we just won't get paid. And I can give you a little list of things that happen, but because there are charges, we bill for these. Okay, so these are things that that we just, we can tell you, we know this is happening. And for like venipunctures, finger sticks, they're all incidental to hemoglobin and if we do any glucose screens. So some things that are incidental to office visits are urine dipsticks, smoking cessation, nutrition services, and implant removals and insertions. So we bill all that stuff with an office visit. We're going to get paid for one or the other. So both things won't pay on the same claim. Those are things we've identified. Those are things that we can't, we're not going to really do anything with. It's just going to happen. It's going to be inherent in our process. Modifier versus place of service, I won't spend a ton of time on that. But this is mostly for those telehealth services that are done at Guidance, where we have an in-person service code of the same service, and we have a telehealth version with a modifier. About midstream of, I don't know, several months into COVID, once they said, okay, we can do telehealth, they said, okay, you use this HQ modifier, but now we're changing, you have to use a telehealth place of service. Well, right now, we don't have a way to make that change in our automated billing system. We don't collect the place of service. We plug it in based on the program. So there's that. I'll just leave it there. Then we have some wrong provider things that Jennifer will talk to you some about those in her presentation, but it's where we have services that, like, for instance, public health lab services that would be under a family planning encounter. And our auto billing system used to, before we were able to automate this and split y'all having to split the encounters up. We would just bill them all to family planning, but we would also bill them in another separate process to the PH lab. So we have things like that that really help explain the difference between billed and paid that you're going to see here shortly. So as Speak of the devil, here we go. Billing revenue reports. So this is a very first time that I have actually on this platform and for this meeting have talked about child health reports. So it's kind of exciting. It's a little bit new to me. I mean, I see the numbers, but I've never really talked about them. So let me find my cheat sheet here. And so here we go. We're state fiscal year 15. It looks like we billed nothing. This is just an overview and a comparison by state fiscal year. And it goes back to 2015 fiscal year all the way to current fiscal year. So in 15, I can tell you that the EPSTT program, where child health is umbrella under, they were the first, as far as on the Medicaid side, to implement requirements for NPIs for ordering and or rendering for some services. And we didn't have anything in place to do that at that point in time. It was all new to us, so we kind of lost some ground there. Also, this is when ACA or the accountability or the I can't now I've lost my note. This is where the ACA marketplace, this is where that happened. And so we lost some Medicaid clients because they got pushed to the marketplace or they became uninsured. So that's my excuses there for 2000 or for state fiscal year 15. 16, we got some of it back as much as we could. And 17, and this happened, and I forgot to mention this earlier, but some of this is ACA related. Some of it was we had leadership, a change in leadership around this time, and some people got a little bit in a panic state in state fiscal year 17 and said we were billing inappropriately for child health. And so we stopped, leadership made the decision to stop the billing. So that's why it's really not there. And then after that leadership we went through that growing phase, they left or whatever, then it was decided after having conversations with Healthcare Authority in state fiscal year 18, we got some of that back and we started billing again. Okay. And then some of it also flowed into the state fiscal year 19 collections. Then here we go, COVID, right? Child health is still going strong during COVID, right? And so what I see there is it's still high, even though we were we were still providing services, obviously. But what happened is I saw an increased usage of the nursing counter, that T1001. So we started billing that more than ever. The volume of the T1001 went up, and we get paid by Medicaid for a nursing counter. So here we go. And then now we kind of got back down, and I think there's a little bit of backlash from 2020 still happening in the state fiscal year 21. There wasn't anything major billing wise, and it could be, I attribute that to the best of my ability. I'm only guessing here, but I think maybe our client volume went down a little bit. Came back up, state fiscal year 22, 23, we're headed to new heights here so far. So that's through, I'm sorry, and I need to say this is through September of 2022 in state fiscal year 23. I haven't reported October yet. So that's only for 3 months. This chart right here is basically just another way to look at the chart I just shared, but this is just grouped by month and then by state fiscal year. So same data. And here's all the revenue behind it, behind both charts. So you can see that. So I have a blooper on the slide, never fails, but these aren't only the top commercial payers for child health, so private insurance for state fiscal year 22, it's all of them. I just need to remove that top. So Blue Cross is our largest private insurance payer. So of course they're on top on pretty much any program that we bill. And so we go through here. These are all the payers that have paid us, or at least, accepted our claims. And we have some difference here. We billed like almost 800 claims in state fiscal year 22 for child health services.
we billed 26,000.5. We were only paid jump change really, but it's a start. This is where these are things that we need to dive into a little more. This is in our plans, and to maximize some of the private insurance opportunities that are still before us. And you'll see the adjusted amount, and that's already deducted from the paid. So the paid amount that's what we paid after adjustments. So for family planning reports, this is again, just like the other slide for child health, but it's for family planning, Medicaid by state fiscal year. Family planning, they were a little delayed in implementing they were delayed in implementing the NPI and the contracting requirements on the claims. So we kind of got lucky there. And then ACA kind of followed suit for state fiscal year 16. Then it's kind of held steady. I mean, if you will, it doesn't look that terrible. And then we're on the upswing for state fiscal year 23. Like that's see, it is only for the first quarter of state fiscal year 23, and we're it looks like we're doing pretty good there. So family planning comparison by month, it's the same thing, same data. It's just grouped differently by month for each state fiscal year, and then you can see the actual revenue received in the table below. Now, this one is true to the title, and it's OSDH top commercial payers for state fiscal year 22 for family planning. Blue Cross on top again. Then we go down through the ranks, and so anything less than 50 claims has been grouped at the very end, just above the private insurance totals. So a total of 14,000 claims, a little more, 1.2 million billed out, only 213 received. Now for family planning, the rates are a little more than what we're going to get paid by Medicaid and by most, well, Medicaid's not on here, but it's kind of follows suit with private insurance. At least they are not paying us every single penny that we bill. Then you have to account for some adjustments that are there, of course, already accounted for. So that 213,000 is what we were actually paid after adjustments. But so the difference between billed and paid is there's a lot of things in there. And this is what I have a hard time and don't have the resources to go in and pull out the exact reasons and explain every single thing. The good news is we are on track to have a dashboard, and it's being worked on currently. I don't know when it's going to go live, but it's super exciting, and it's going to make my job a lot easier on reporting, and it's really going to allow a lot of folks that want access to it to go in and run their own reports. So when we get to that dashboard and when it gets done, it's going to explain some of these differences a lot easier and quicker than what I can. But I can, I can give you reasons why, it's either, a not, it's maybe a not covered service and that type of things there, and build more than what we get paid. And there's just a lot of things involved in explaining the differences. It's not that I don't want to, it's just I just don't have the resources to do it. But I'm hopeful that this dashboard will fill in those gaps that I can't fill right now. So for maternity, this is exciting too. So it looks a lot like at least state fiscal year 15, it was really big, and then kind of drops off state fiscal year 16. And so a lot of that is ACA went into effect, and so did the restrictions on or more restrictive claims requiring contracts and NPIs being on the claim for some ordering NPIs and rendering NPIs on the claim. So we had to do that. And the other thing I thought of over lunch was the one thing that maternity, how it differs from most other providers that I'm talking about today is it was all manually billed by billing staff from from beginning of time through state fiscal year 19 when it ended early in that fiscal year. Then we have 20 and 21 fiscal years where we didn't do any billing, and then we just started picking up billing again. For state fiscal year 22, we billed, and then 23. So I see that growing exponentially based on where we're at in the first 3 months of state fiscal year 23. Again, this is the same chart, just arranged in a different manner by state fiscal year and comparison by month. And here is the chart data that goes with it with all the revenue amounts. So here are the office contacts for medical billing. We have a group email that is monitored every day. We have a phone number, a fax, all listed here. And our billing staff, including myself, we're all on this list. This is how you get a hold of us. This is, you directly email us, or we're reachable on Teams. You can call us on Teams, or you can message us on Teams. And with that, I do appreciate each and every one of you. And if you have any questions, feel free to let me know now or reach out to me later. Are there any questions? And can y'all still hear me?
We can still hear you. I don't see any questions at this time in the chat, but if you have any questions, please put it in the chat, or you can unmute at this time.
Thank you all so much. I appreciate you.
Oh. Hello?
Yeah,
Yes.
we heard you.
Okay, good. Sorry. This is Jana Finch. I'm one of the nurse practitioners in District 5. My question is, how can we as providers, how can I as a provider make your job easier?
Oh gosh.
So,
I mean,
so
y'all
as I'm
already do a
filling out,
lot.
as I'm filling out the BCD, are we going to go into that and stuff? Because sometimes I worry that I'm doing it wrong and then creating work for other people. And I came in, I started in March of 2020, so my orientation
Yes.
was swift and furious, and I just was thrown in. So I've learned as I went. So anyway, I just was curious. That was my question, was how can I as a provider make your job easier and make it flow a little better, so that we're not having a bunch of errors on my end without me knowing that I'm making errors? Does that make sense?
It makes perfect sense, and I really do appreciate that. And Jennifer
Sure.
just went to the car because the connection here is really cruddy, and she is going to cover some information on BCDs. So that will be perfect, and she's going to point out some errors and things like that, things that might be overlooked. But for me personally, I think y'all are doing a heck of a job. And the contracting piece for me is just, what I can bring to the table with that is just maintain your contracts. Let me know if you have any hiccups on your contracts, if you see anything weird or you have questions, and just know
Okay.
that I do have the instructions on how to go through the contracts. But this just makes your question just brought this to mind, is those instructions are because of what you all see. And when there is a change in how you complete the contracts, or if a question changes, I don't know that. I'm not an individual provider. Okay. So I rely on your eyes. Okay. When you go into your contracts, especially at renewal, if anything has changed, because I don't always know that. And when you're following my instructions, that's real helpful for me to know if I need to update them, if something has changed. So that's the one thing that just comes to mind for me. So thank you, Jana, very much.
Sure. So just to clarify, you help us with our Medicaid contracts, or Medicare contracts, excuse me. So that's okay. I'm sorry. I'm just connecting all the dots.
Yeah, and I do the billing side too, but Jennifer is the focus guru and the BCDs and all of that stuff.
Cool.
So
okay,
she's going to be covering that here pretty quick.
Cool. Thank you so much.
You're welcome.
All right. If you all have any questions at this time, please feel free to add those in the chat or you can unmute your mics. Jolene, I don't see anything in the chat right now at this time.
Thank you very much. And
All right. Now,
Jennifer should be.
okay. All right. Ira, we will turn it over to you. I don't see Jennifer yet. So any updates that you would like to provide? Oh, she just hopped on.
I'm on. I'm on. If you guys can hear me.
We can.
Okay. I went to my car to see if it would be better. Okay. You guys have my slides that you guys can share for me, please? Thank you. All right. So we're just going to talk a little bit about some of the focus related updates for you guys. Go ahead and move on to the next slide, please. So, and this is really, I'm not sure who's on the call, but this is geared towards APRNs as well as clerical staff, because you both play a role in what we need to get into focus for documentation and for billing purposes. So on the client insurance side, we do want to make sure that the name that's on the client's insurance card or that's in their Medicaid eligibility lookup matches the name that we have for them in the focus insurance module. This is the information that populates the PAP requisition that you print out of focus. And that name has to match what's particularly the Medicaid eligibility lookup in order for CPL to properly bill Medicaid. Otherwise, that client ends up on the list that gets back to Jill and her group, and they have to go through, review it and look it up and say, oh, this is a Medicaid person, it should be billed to Medicaid. So we want to make sure that the names are matching. Also, we get, as Jolyn mentioned, the denials and rejections when the client's names aren't correct in our system. Also, for the lab purposes, the same name has to appear on the specimens. So the name that we have legally in our system, particularly for insurance information, does have to match what is on the lab requisitions, what is on the specimen tubes. Also wanted to mention that we provide services to all clients, irrespective of the payer. So whether the client is self-pay, and they would be on a sliding fee scale if they are self-pay, anywhere from 0% owed to 100% owed, depending on their household income. But whether they're a self-pay client or have any one of the 170 plus insurance companies that we have on our focus pick list, we're providing same services to all clients. We do try to bill everything to third-party payer. For family planning services in particular, if the client is self-pay, they are responsible for those charges on that sliding fee scale basis. But we do try to collect as much as we can from the third-party payers. If the client does not want their insurance to be billed, confidentiality purposes, we do need to mark on the client cover sheet, do not bill. And that usually is something that the clerical staff will do based on questions that are asked on the demographics report when the client checks in. But it might also come up during the provider session when the provider is seeing the client. And so we still want to make sure that that is marked on the client cover sheet. And then the provider would initial on the super bill the 1714 do not bill code. And that prevents billing from occurring, claims from being sent to the private insurance companies. We do still send the claims to Medicaid, but this will prevent the private insurance from being billed because the client does not want that explanation of benefits going back to their home. So that's really the purpose of that. But make sure that we get that information from the client and that we mark the appropriate places. Next slide, please. Just a quick update on the health stat and testing information. We haven't really done anything. We haven't made any changes yet, but this information was rolled out. New information was rolled out to be able to collect better data that's required for the family planning annual report. For family planning programs, responses for all the fields are required. They're not required for non-family planning programs. We do have a lot of those fields accessible and open for other programs, however. And we have been trying to get some information from staff regarding when it's appropriate to have contraceptive information open and when not to. And so we are making changes to what's available depending on the program and the encounter type. So look for that upcoming. But for family planning encounters, all of those fields will always be available. They're all needed to be completed. If you find that there is a response that you need for the work that you're doing and that response is not available to you, let us know, please. We used all the responses that came from the FPAR 2.0 guidance, and we found that that guidance didn't really cover all of our situations. For example, on the testing side, we do HIV 1 and 2 testing, and that wasn't a test type for, from the feds. So we added it for ourselves. Doesn't map to anything for the feds, but it's what we're doing right now. And we're going to have to work about how we'll have to work on to how we're mapping these things for our own purposes. But if there is a response that's not there for you, let us know, please. And we can see what we can do to get that information to you. We'll have to have a discussion about it just to get some more details on it. On the super bill, just a reminder that family planning billing codes are all shaded and that those are the codes that should be used in the family planning visits and only in family planning visits. Services that are not shaded are not on the family planning fee schedule, and there's a difference in the rates for those services. We, as Jolyn kind of alluded to and mentioned in her talk, we are seeing the family planning lab codes in particular that are being used for other program visits, like STD visits. And we have been running some queries on the back end just for QA purposes to see how the data are showing up, what the documentation is looking like, and to see if we need to make some corrections in the system. And we have already sent some things out where, hold on a second, I just saw something pop up, so I'll go look in the chat in a moment. But we are seeing, sending some corrections out already for some things that we've been seeing. What was that question that just came up?
Okay, so I can help you with that. So it's a statement saying it's confusing because of 1423, the STI on the STI portion is shaded.
Okay, yeah, there's, I mean, the forms don't really have anything to do with each other. They're different forms. So what we shaded was the smallest portion of the form, and my super bill came first. But no, it really is just a matter of what's less, so rather than having almost all of the form be shaded, we went with the smallest portion on what got shaded. I'm not sure why the 1427 that's the other form. I'm not sure why that one went with STI portion to be shaded, but it's probably the same reason, that's for a specific program, and it was easier to set that apart than it was to set apart the other piece.
There is, Jennifer.
But it also says, okay, I was also going to say, though, it also is the heading that's above that shaded section. It says family planning. So there's also some text in there that also indicates that it's family planning specific. What's the other question?
So there's a comment, and I believe you just addressed it. I've noticed that the super bill is photocopied of the original forms. The shaded areas do not show up. So I don't know if we need to get some better copies sent to them, or is that available somewhere to where they can see the shaded areas?
Yeah, we don't photocopy. We don't make copies of the BCDs. We could make them darker. I don't know how it would come out if it were darker. I don't know how that would show. So we can play around with it. I know everyone's copier machine is a little different. And so what happens in one machine doesn't necessarily look the same on somebody else's machine. That's just something that we'd have to play around with.
Okay,
So
that's it.
that-
Thank you.
That was my comment. I'm sorry. This is Jana again. I was noticing that if the original forms aren't used in the chart and instead the original forms are used to produce photocopies that then we fill out, those photocopies they're not filled out yet. So those photocopies then don't have the shaded areas on it as obvious. Does that make sense what I'm saying?
Yeah.
Okay.
Yeah. I mean, you just have to rely on the heading that's listed above that section. I mean, I think if we make it darker, it's going to be difficult to see. I've heard that. So, I mean, we can continue to play around with it and see if there's anything that could make it any better. We could try to make it a shade darker than it is right now. I'm just afraid that it would be too difficult to see at that point.
There's also some suggestions that some people print them right off of Health Hub under the focus BCDs, and it seems to help. So
Okay.
that's all I have. They're just some comments on how to help in that area.
Yeah. In a couple more years, we won't have BCDs. It'll all be in the EHR, but it's still a couple of years. So we've got to figure out a way to work with this better. I hear you. All right, let's go on to the next slide, please. So common encounter errors that we're seeing. We have noticed that I will say my record staff have noticed that there are multiple encounters that are occurring or visits that perhaps should not be the case. So if a client, I'm just an example, if a client is coming in to one facility receiving family planning services, STD services, immunizations, and they're all in the same location, same visit, that should all be one health encounter, one health stat, one encounter. The exception, of course, is one that we recently made August 1st, which is that PHL encounter. The labs for Medicaid clients go in a separate encounter. If a client has to go to another facility, say they came in for immunizations and you don't have the immunization there that they need, the shot that they need, so they get some service there at your site, but then they go to another site to get a different service. That is a separate encounter. That is 2 different visits. Those are exceptions. But generally, if a client is coming into one facility at one time, they're getting, even the same day, they're going to get one encounter. We're also seeing incorrect service codes that are being documented in focus encounters, and I'll show you an example of that. We're seeing where the public health labs, the PHL labs, are not going into a separate encounter for Medicaid clients. And we're seeing the PHL encounters being created for Medicaid clients, but that the wrong codes are being added to it. So just different things that we're seeing in the system. And these are all things that we're running queries on, and we're looking to find these errors. And we'll be sending them to the county health departments with an explanation to have them make the corrections. So go ahead and, okay, question about what encounters need to be PHL. Can you go back to the super bill slide, please? I don't know if you can zoom in on that, but on the bottom right corner, it says, note labs that are bolded, italicized must be entered in a separate PHL encounter and PAR from other services, Medicaid clients only. So we have some services here that are bolded and italicized, and they're a little bit larger font. Right now, it's chlamydia, gonorrhea, HIV, syphilis, HPV, and these are the family planning codes and the non-family planning codes, and monkeypox. Those are the ones that are that should be going into a separate public health lab encounter. It doesn't matter what program the client is in for. Family planning, STD, it doesn't matter what the program is. If they are getting that service that is bolded and italicized and they're a Medicaid client, then that PHL encounter must be added. And that is a task for the clerical staff to have to look at that, note that it's a Medicaid client, note that it's a service that's bolded and italicized, and putting that into focus that way.
Jennifer, you have 2 questions.
Okay.
What services need to be under the PHL encounter for Medicaid clients? That's the first one.
Okay. And that's the one that I was just talking about.
Okay, perfect. So the second one is, so the PAP isn't, but HPV is, I'm guessing, of the
For
statement that you
now.
just mentioned.
For now, correct.
Okay.
We have not changed the labs that are bolded and italicized. We're not looking at where they're going right now. That's not for you guys to worry about where they're going right now. On the billing side, that is something that we're investigating, that we need to look at our contract and see what's specified by our contract and look at the claims that are coming in and how we're getting paid. So for now, all you need to worry about is what is bolded and italicized on the super bill.
And one last question. Does it matter if the HIV and syphilis goes to the CPL and
Nope.
not the PHL?
Nope. Not right now. Nope. Right now, they're still bolded and italicized, so they still go into the PHL encounter. It relates to how we're billing them. It relates to, so before August 1st, all of our labs for Medicaid clients were being billed directly out of Labware. We're pulling a flat file out of that system, doing some data manipulation, and creating the 837 claim files out of Labware. Effective August 1st, we moved all of that into Focus. We were already using the billing codes in Focus anyway. We just switched the process for the claims generation to happen through Focus. And the difference is that the way that we contract with Medicaid with labs is different. But we need to look at whether it's labs going to the public health lab or it's all labs that we do, or it's all labs that are going to a lab versus point of care labs. So we still have to do some digging on our end to decide that. So right now we've got just the labs that we've bolded and italicized that are going into that separate PHL encounter. So that's all you guys need to worry about. If it's bolded and italicized on the BCD, that's the one that's going into a separate encounter for Medicaid clients only.
Okay, there's no additional questions at this time.
Okay. Yeah, it's very confusing. I'm sorry. It's just, it's the way it happened. We have to make sure we have the right ordering provider in there and the right MPI number. It's under CLIA. So it's just how it's got to be in the system right now. All right, go ahead on to the next slide that has an encounter. So here's an example of an encounter, and I've blacked out all of the names, clinic information, encounter IDs, all the identifying information that's on here. But if you look at this is an STD program encounter. And this was on May 3rd of this year. But if you look at the codes that are being used in this, that are documented here, it's family planning codes. So the syphilis, HIV, chlamydia, and gonorrhea codes are all the family planning ones. And because it's an STD encounter, this needs to be the non-family planning codes for those particular items. And it's because of the billing. It's a different rate. Well, I can say it's generally a lower rate for family planning services, not always, I mean, for non-family planning services, not always, but usually it is. So this would be a correction that would be needed to be made. Those codes would need to be deleted from here and switched over into the other system. And because this is an STD encounter from May, and it's also a Blue Cross client, everything stays in this one encounter. Let's go on to the next slide, please. So here's another one. It's also to Blue Cross. It's also STD program, but we've got a mix of codes in here that are family planning and non-family planning codes. So the gonorrhea and the HIV codes are correct. These are the non-family planning ones, but the chlamydia and the syphilis codes need to be switched to whatever the respective non-family planning codes are. Go ahead and go to the next slide. This is an example of a family planning program code. I cut off the insurance information, but this is a Medicaid client. This is from September 20th. So August 1st is when we switched to billing with the PHL encounter, August 1st. So everything August 1st and later, those labs that are specified on the BCD need to be in their own encounter. So in this case, we need to take, so in this case, the right codes are used. It's a family planning visit and we have the appropriate family planning codes, but we need to take syphilis, HIV, chlamydia, and gonorrhea. Those are the only ones. Yep. Those 4 need to come out of this encounter. So delete them from here and add a PHL encounter and put just those 4 services in the PHL encounter. Go ahead to the next slide. All right, on this one, so this is the same client, same data service. So they came in for a family planning visit. They had all these services. They got all those labs. The person entering the data recognized that there are labs that have to go in a public health lab encounter. So this is great. We've got the split that we need for public health lab for these particular labs. The problem is that PAP got pulled into the public health lab encounter and the wet prep got pulled into the public health lab encounter. And those 2 things should be up in the original family planning encounter. Those aren't bolded and italicized on the BCD. So I see that they both show up on that original encounter as well, but they got pulled into the PHL one too, and they shouldn't be down there. So we would just need to go into the PHL lab only encounter and remove those services from the bottom and then just edit and save and it'd be fine. All right, let's go on to the next slide. So just a quick review on the incidental visit. We talked about this, I know in some other trainings that we've done before, but just as a reminder, in the family planning manual, it does talk about the use of incidental visit. And this is when clients are not supposed to be charged for an office visit, but they do return to the health department for some service. And it's usually when they're returning for a reason. It's not usually, it's only if they're returning for a reason that's we've made a mistake of some kind, there's some kind of clinic error, we're asking them to come back for some reason. So the example here is a repeat PAP. We didn't collect an appropriate specimen that could be tested well. There was just some problem with that specimen. We asked them to come back. That would be an incidental visit. And we don't charge them for that. If we run out of birth control and we are getting a new shipment in at the end of the week and we ask them to come back at the end of the week and they return to pick up their packet of pills, that would be an incidental visit. We're not charging them to return, but we are charging them for the supply. But that would be an incidental visit. So if we're asking them to come back because of a mistake on our side, then that's when we use the incidental visit. If we give them 3 months of birth control at a time and they come back 3 months later to get their next 3 months of birth control, that would not be an incidental visit. That would be an office visit, whatever it is you normally code for that, not an incidental visit. And then the last slide is just our contact information, I believe. Oh, actually, there isn't a last slide because that's what I sent to you guys first. So I had a slide on my presentation that had contact information. I did want to mention, and I'll put this in the chat for you guys, that beginning, see if I can type while I talk. Beginning November 1st, we are, Focus Help Desk, we are, I say we, Vicki Foster and I are no longer going to be in the OMES service desk. So when we do permissions for Focus and inventory supplies and stuff, we're hooked into the OMES service desk and we get those requests through there. And we're not going to be doing that anymore. We've set up an inbox and it's Focus Help Desk at health.ok.gov. And I'm typing that into the chat. This is what we would like for you to use when you are needing any permissions changes for Focus, inventory supply system, LEP, the IMI COVID testing portal. We do permissions for all of those systems. And so we'd like you to reach out to this help desk if you are needing changes to that, to those permissions, but also for any other Focus questions that you might have. If you're having problems with Focus, let us know here. It might be that we need to reach out to OMES, but we might be able to help you with your issues. So any kind of questions or concerns related to Focus, any permissions that you need related to Focus and the other systems, go ahead and send it to this email address. I've got a memo prepped. Since I'm out somewhere right now where I don't have access, good connectivity, I'm not able to send my memo out. So I'm going to do that when I get home to see if we can get this memo sent out. This will be effective November 1st. So that's Tuesday of next week. This help desk is actually already live. So if you do send something to it, we will see it. And the record staff are the ones that will be monitoring this inbox. So Vicki Foster, Sharon Ray, and Mary Richards are the ones that will be monitoring this help desk. Do you guys have any other questions for me?
Maybe at this time, if you have any other questions, please feel free to unmute your mics or add those in the chat. Right now, I don't see any additional comments.
All right, well, let me know if anything does come up. And thank you for having me on here today.
All right, thank you. Ira, we'll turn it back over to you.
Thank you both Jennifer and Jolynn for sharing information on our current contractors and how billing translates into continued services for the communities we serve. Our next presenters will be Jill Nobles-Botkin and Misty Hammonds. Jill is the current Title X Administrative Program Manager for Family Health Services here at the OSDH Central Office. Jill will be providing us with updates from the Title X program, as well as updates on the maternity care program. Misty is the nurse practitioner consultant with our child and adolescent health programs. She'll be providing updates and information related to our child health clinics. We will now hear from Jill and Misty.
Jill, you're on mute.
You would think after doing this all day that I would remember to look at that. Sorry. Good afternoon. I want to thank all of you for joining us this afternoon. As Ira mentioned, I'm the Administrative Program Manager for Perinatal and Reproductive Health and the Title X Director. And this training is one of the mandatory trainings that we have to do for Title X. But we also wanted to share some information today about maternity and child health with you, since most of our staff that are providing maternity and child health services are also involved in family planning. We thought it would just be a good way to catch everyone and share information. So once again, thank you for joining us, and I'm going to share my screen, turn my camera off and share my screen now so that we can get started.
We can see your screen.
Whoops. Wait. Whoops. Trying to put it into presenter mode here, and there we go. All right. So first of all, I just wanted to start out introducing the staff in MCH. So in the division that I'm the manager for perinatal and reproductive health, I have 3 APRNs working with me. Many of you might be familiar with them as they've been covering a lot of clinics across the state in the last few months. So you might have seen them out in the clinic. And that is Hillary Miller, Nikki Gard, and Amy Foster. So we appreciate their willingness to travel around and help make sure that we can still provide family planning services to our clients, even though your practitioners either have left and you're waiting to hire someone, or are out on surgery or maternity leave, or whatever the reasons are that they're busy. We are thankful that we have the ability to cover those clinics. Then we have Tony Fleshman, who is our expert on anything that has to do with manuals and forms. You've already met Ira today, who is our health educator. And our administrative support right now is Janet Hamlin, and we have a vacant position that we're getting ready to hire for. In the Child and Adolescent Health Division, Alicia Lincoln is the program manager. You will meet Misty and shortly if you have not met her already. She is the APRN in Child and Adolescent Health. Then they have the Early Childhood Coordinator, who is Peggy Byerly, School Health Coordinator, who is Gail Black, the School Health Consultant, who is Megan Sylvester. You may know her as Pridgeon. She just got married recently. The Adolescent Health Coordinator, Brittany Clark, who also just got married, changed her name recently. And then Janet supports, and the vacant position supports the Child and Adolescent Health Division too.
Jill,
then,
before you move forward, I don't think we see you advancing your slide.
Oh no. Okay. Whoops. Can you see it if I do it this way?
No, it's still on the main screen,
Well,
the main slide.
let me stop sharing and do this one more time.
Now we can see. Thank you.
Okay, well, this looks totally different on my side from what I saw earlier, but we'll do it this way if that works. So, okay, so there's a slide with everybody's name for for perinatal and reproductive health, and then child and adolescent health. And you can read those. Then additionally, I'd like to just recognize the maternal child health director, which is Joyce Marshall, and our epidemiology support for perinatal and reproductive health. Jenna Ballantoni just joined us recently, and then Thad Burke supports the Child and Adolescent Health Division. So now we'll get into the important things. First of all, today I have to go through the annual reminders. This is a requirement from the Title X grant that we review these with you verbally, and then that you sign the paper that we have you sign every year that says you're aware of all these things. Just so you know, it's a requirement. That's why we're doing it. So I'm basically going to read these to make sure that I cover everything, even though I know that you can read. We're just going to read through them. So I apologize for that, but we have to remind you of these. So First of all, services must be provided without subjecting individuals to any coercion to accept services or to employ or not employ any particular method of family planning. Acceptance of services must be voluntary, and we cannot make any services be a prerequisite to eligibility for or receipt of services from any other programs that we offer at the health department. Also, any employee of the federal government or the state, political subdivisions of the state, or anyone that administers or supervises the administration of federal funds or receives federal funds under this program cannot coerce or endeavor to coerce any person to undergo an abortion or sterilization procedure by threatening such person with the loss of or disqualification for the receipt of any benefit or service under the program receiving federal assistance. And you can be fined not more than $1,000 or imprisoned for not more than 1 year or both if you're found guilty of this. OSDH also, well, the federally we're required to protect client information as well as our OSDH policy to protect confidential information. And we have the policy noted there about HIPAA and the fact that we are trained annually on HIPAA. Services must be provided in a manner that does not discriminate against any client based on their religion, race, color, national origin, disability, age, sex, sexual orientation, gender identity, sexual characteristics, number of pregnancies, or marital status. Services must be provided without the imposition of any durational residency requirements or requirements that the clients be referred by a physician, which means that anybody in the state of Oklahoma or those living along the border that live, just across the border, we can provide services to anyone coming into our county health departments that do not have to live in the county that you're providing services in. Also, the secretary is authorized to make grants and enter contracts with organizations to assist in the establishment and operation of voluntary family planning projects, which shall offer a broad range of acceptable and effective family planning methods and services, including natural family planning, infertility services, and services to adolescents. And to the extent practical, we have to encourage family participation. We can't make that mandate. We can't allow parents to consent for minors, and we'll get into that more in a minute. So, but we do need to encourage family participation. In that every person having reason to believe that a child under the age of 18 is a victim of abuse or neglect shall report the matter immediately to the Department of Human Services. And that's why we have a totally separate training that's also a mandatory training, which usually occurs at the beginning of the year in January or February. So, as I mentioned, family planning services have to include a broad range of medically approved services, which include all the FDA approved contraceptives and natural family planning that for clients that want to prevent pregnancy and space their births, for pregnancy testing and counseling, assistance to achieve pregnancy, basic infertility services, sexually transmitted infection services, and other preconception health services. Client-centered care must be provided that is respectful of and responsive to individual client preferences, needs, and values, and that the client values should guide our clinical decisions within the boundaries of evidence-based healthcare. That we have to provide quality family planning services that are consistent with the providing quality family planning services recommendations from the Centers for Disease Control and Prevention and the U.S. Office of Population Affairs, which after this will be referred to as the QFP, and also other relevant nationally recognized standards of care. And the new requirement with this grant cycle is a focus more on equity. So we're required to advance health equity through the delivery of Title X services. And they define health equity as when all persons have the opportunity to attain their full health potential and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. And we've provided all of the references to the federal statute in case you want to investigate more or curious, you can find these requirements there where we've noted. In addition, information about the adolescent services, like I mentioned, to the extent practical, we have to encourage family participation, that we cannot require the consent of parents or guardians for the provision of services to minors. And we can't notify the parent or guardian before we provide health services, except for when we add immunizations or other procedures onto the services that are being provided. So that's why we make it very clear that the parents cannot sign the consent form with the adolescents, because it has to be clear that they're consenting for services and we're not requiring that. But also, if we add services like immunizations, we have to have a separate consent then, because those services do require parental consent. And then we're required to provide counseling to minors on how to resist attempts to coerce them into sexual activities that they're not ready for. So now you're prepared to sign a Title 10 acknowledgement sheet that we have created, and that needs to be on file when we do site visits. So I don't want to even pretend to be as good as Dr. Pai. If you've heard Dr. Pai, our medical director, give a presentation, she is a Disney fan and she can incorporate Disney into just about anything. So I'm not even that good, but I wanted to share some thoughts today from Disney. I looked back last year in the presentation and used Dr. Seuss. So this year we're going to use some Disney quotes. So the first one is to remind everyone that sometimes we only see how people are different from us, but if you look hard enough, you can see how much we're all alike. Our thought for the day from Jasmine. So the next section here, as I wanted to share with you our work plan. Every time that we submit a competitive application, we have to create a work plan that says what we're going to do through our family planning project. And the work plan's kind of changed over the years. And this one is a new format. So I wanted to share with you why we're doing some of the things we're doing and what we're doing, because we are in a new grant cycle that started April 1, and we have this grant for the next 5 years. So we have 4 basic goals in this work plan. The first one is to advance health equity through the delivery of Title 10 family planning services. And we're going to do that through increasing health equity through the delivery of services to historically underserved populations in Oklahoma. And then this just relates back to some of the topics that we covered. We're going to provide the services by not discriminating against any client. We're not going to subject individuals or coerce them into accepting any services or choosing any particular method. That our services are going to be provided in a client-centered way so that we're taking into consideration their needs and desires. And also that we're going to try and provide services culturally and linguistically appropriate. It's going to be inclusive and trauma-informed. We're also going to protect the dignity of the individual and ensure that equitable quality service delivery is consistent with nationally recognized standards. Again, we're going to provide them as required, but not based on durational residency requirements by whoever shows up for services. We're going to coordinate referrals for services that clients need that are outside the scope of the family planning program or OSDH. We're going to encourage and mentor clients on the importance of family involvement, healthy relationships, and avoiding sexual risk, especially but not only when communicating with adolescents. In the last grant cycle, we had to document why clients were not including their family members if they were adolescents. And so they removed that requirement now, but they still want us to focus on providing that information but with adults, not just adolescents. Since we have some of our clients that are in domestic violence situations, they want us to be aware and make sure that we promote the information to all clients that need it. We're going to educate family planning staff on reducing disparities and improving health equity. And that's one of the reasons that we have Kamisha within the MCH family. So her focus is to help us make sure that we are including health equity in all aspects of the services that we provide. And we're going to decrease barriers to accessing treatment for substance use and behavioral health issues. And we're addressing that somewhat through the CHESS health intervention application that we have available, and we'll discuss that a little bit more in a few minutes. So goal number 2 is to improve and expand access to the Title X family planning services for all clients, especially the low-income clients. We're going to ensure that all Oklahomans are aware of the services and have access to the services that we provide, regardless of their income or geographical location. So one of our goals has always been to ensure services are prioritized to low-income clients, with at least 95% of our clients reporting incomes less than or equal to 250% of federal poverty. And I can say that for the time that I've been the Title X director, we have no problems meeting that. Usually about 97 to 98% of all the clients that we provide services to are less than 250% of federal poverty. So we easily can meet that goal. The second one is expanding access to Title X family planning services and increasing the number of clients that live farther away from the brick and mortar buildings. And I'm not sure what each district is doing with their mobile units, but from what I hear and meetings that I'm on, I think that you are all doing a great job of reaching those areas that traditionally haven't been served, or that clients have a hard time making it to the brick and mortar buildings from. So kudos to you for identifying those gaps in services and trying to meet those clients where they are. I have to ensure that all services provided through our contract agencies are provided in accordance with a family planning fee schedule, which is why those of you from Oklahoma City and Tulsa have to submit your fee schedules for approval to us and provide your services on the same type of fee schedule that we do. We are going to focus on increasing access to reproductive health services and education for hard to reach youth. And we specifically do that through a contract we have with Youth Services of Tulsa. But I know that all of you, and we've been out before out in the counties, either helping or doing site visits. I know that a big focus is on reaching the adolescents and making sure that they have services when they can get to the clinics, not turning them away if they come into the clinic and they don't have an appointment, but just providing services to them and making sure that they have access to everything that they need. So we're also going to provide opportunities for community education, participation, and engagement to achieve community understanding of the objectives of the program, inform the community of available services, promote continued participation in the project by diverse persons to whom family planning services may be beneficial, to make sure that everyone has equitable, affordable, client-centered, quality family planning services. And the first part of this objective is one of the reasons that we had the community participation plans, because we're required to, at the local level, to educate the community and engage them in making sure that the services we provide are meeting the needs of your communities. We have some more tasks for goal 2, I forgot. So we have to establish financial policies that are in accordance with federal regulations, which means that we develop the fee schedule of discounts, which are based on people's ability to pay. We have to assess family incomes before we assess any co-payments for people that have insurance. And we have to make sure that for those clients with insurance that we don't assess them a fee that's more than what they would pay for their co-pays. We can't give them a copay that's greater than what they would pay if they were just assessed on the sliding fee scale. Can you still see my presentation?
No, somehow it disappeared.
I was gonna say, I can't see my presentation, so. I'm not quite sure what happened there.
You remember what slide you're on? I have them up if needed.
Okay, just go ahead, because I'm not quite sure what's happening on my side this afternoon.
Oh, it looks like it popped back up. We can see it again.
I think this is the slide we were on.
Okay, perfect. We can see it.
Okay, and you can hear me okay this afternoon?
Yes, we can
Okay.
clearly.
Good deal. Okay. Okay, so I think we were on major task 7, which was taking reasonable measures to verify the client income without burdening the clients too much. And so we have to try and verify, not just take what the client says on income, but we need to try and verify. But for some people, that's very difficult. So if we can't verify that, we'll allow them to just state their income. We also will seek third-party reimbursement if they have insurance, and there is another company that should be obligated to pay for the services. We'll make sure that protected health information is kept confidential. And then here's where I added in the encourage family participation, but not requiring consent of adults. So the third goal is to deliver Title X family planning services that are of the highest quality and consistent with nationally recognized standards of care. Again, we're going to provide those, make sure that we're providing those to low income and uninsured or underinsured clients who are trying to get pregnant, who are trying to prevent pregnancy, and provide the related preventive health services also, including infertility counseling and using the natural family planning methods. So one of the advantages of the Title X clinics over some other private offices and some FQHCs is that we have a broad range of acceptable and approved methods of family planning, and also that we have LARCs in our clinics, the Nexplanon and the IUDs, for same-day insertion. A lot of times in other places, clients have to come in and then those devices are ordered and they have to come back. So as long as we can reasonably rule out pregnancy, we can go as far as inserting LARCs on the same day that they're in the clinic, which makes us have an advantage for clients that are choosing those methods. We are going to provide services, as I mentioned, according to the guidelines in the QFP. And in case you're not familiar with that, these guidelines were jointly created by the Office of Population Affairs and the CDC back in 2014. They've done some minor updates in 2015 and 2017, but basically have stayed the same. And this document provides recommendations on providing clinical care and some of the other related preventive health services and counseling. So it's a pretty comprehensive it's pretty document. And so I've provided the link there in case you have not seen it or you're not familiar with it, and you can check it out if you're interested. I already talked about same-day access for LARCs. I got ahead of myself, I guess. Major task number 4 is providing options counseling. And I know there's some questions about that, and I'm going to touch on that briefly in a minute. We're also going to focus on reducing infertility among men and women attending our Title X clinics by identifying chlamydia and gonorrhea infections and getting them treated. And we're going to focus, especially according to the CDC guidelines, on those clients that are less than or equal to 24 years of age. We're going to maintain low positivity rates for HIV and AIDS by offering this testing and for testing clients that have risk factors. We're going to educate all family planning healthcare providers to ensure that service delivery is according to the nationally recognized recommendations and federal requirements and in accordance with evidence-based practice. And we do that through our policies and procedures and also our APR inform. We're providing counseling referral to other agencies as indicated, like I mentioned. And then our last goal is implementing quality improvement and quality assurance plans to monitor and evaluate the Title X services. So our goal is that we will monitor 100% of our service sites and contract agencies annually. Now we've gotten away from our normal monitoring plan due to COVID, when everybody was either detailed to doing other duties and had other responsibilities, and nobody was really in the clinic to provide family planning services, because we are required to observe you providing family planning services. So we are working back towards our normal routine for monitoring, which means that a certain number of you will get a comprehensive program review visit, and then everybody else will get an annual monitoring visit. And the annual monitoring visits are actually set up to follow up on the comprehensive program review visits, so that we can see if there was any requirements, to make sure that the requirements have been addressed, and then just to monitor for things that may have changed, like staffing, maybe you've changed locations, because it seems to me there's several location changes recently, so. And those kind of things. So our goal is to monitor everyone in some way, 100% of the sites, to monitor them every year. So then another way to do this is through the family planning annual report, which we are required to complete. Jennifer mentioned that earlier, that we did add the health stats, or we edited the health stats and expanded it this year so that we are able to provide encounter level data that's required by the Office of Population Affairs in our annual report. We also added a task in of acquiring an electronic health record. And I'm happy to say that if you missed the town hall meeting the other day, Keith told us that we do have funding now for an electronic health record, and we will be moving forward on that. But Jennifer also mentioned it's going to take a couple of years, so it's not going to be quick, but we are actually going to move forward with electronic health record, I think. I've kind of touched on major task 3 already. I got out of order this time, so. We also do an annual visit to all the nurse practitioners, just to observe services and make sure that everybody has what they need from us as far as education and resources. And then we're to provide, to the maximum feasible extent, an opportunity for participation in the development, implementation, and evaluation of the project by persons broadly representative of all significant elements of the populations we serve, and by others in the community that are knowledgeable about the community's needs for family planning and services. So this we do through the community participation plans and also through the IME committee. So now that's enough of serious stuff. We have another moment of Disney here. Sometimes, I know that's kind of hard stuff. It feels like the human world is a mess, especially the last few years. But I want to give everyone kudos, because as public health professionals, we just keep swimming, and we do what we have to do to meet the needs of our populations in your respective areas. So now I want to move on to some things that are specifically related to the services that we're providing in the county health departments. Sometimes we do great things, and sometimes we need some little reminders to help us improve services. So I didn't see Jolynn and Jennifer's PowerPoints until this morning, so there's a little bit of overlap here, but just as a reminder that we need the client's address It's the unique identifier that has taken the place of the Social Security number for billing purposes. So when you submit the lab requisitions, we need the client address. The name on the file has to match the name on the requisition, has to match the name on the insurance card. We have to have a diagnosis code included for lab requisitions. And just so you know, we get requests every month from CPL for additional information. And most of the time, if they're asking for additional information, they're asking for addresses, the Medicaid number, the NPI number for APRNs, which I can't quite figure out why that's not in the system, because all of the APRNs should be in the system. But we get that, and also the diagnosis code. So just a reminder to make sure that you've included all this information when you're making a lab, you're ordering lab tests. And here's my annual reminder on LARCs. In the past, we've had multiple funding streams for our Nexplanon and our IUDs, which are the long-acting reversible contraceptives. I think that all of them are gone. I think that all of the devices purchased with CHI funds, they used to have this sticker on there that said CHI, have all been inserted. So I think we only have two types of LARCs out there now, Title 10 and then the ones purchased with CHIP funding. So as a reminder, Title 10 devices can be used in anybody of any age, anytime. We're grateful for the partnership with the Healthcare Authority and the funds from the Children's Health Insurance Program that provided additional LARCs for us. If you haven't been here for a long time, you may not know that a few years ago, we had a waiting list for clients that wanted these devices. And so that's where this partnership came from. But the CHIP devices can only be inserted in those clients under 19 years old and uninsured. Now, the caveat to that is if you're providing confidential services and you're adding that confidential billing code 1714, then you can use the CHIP devices, but you need to let me know so that when we run the report and they come up in the report, that I can take those out. I'm going to jump ahead for just a minute to the next slide. So we just ran information on the CHIP devices because I have to report to the Healthcare Authority. And just so you know, these are all the ones that were miscoded. For the ones that have Medicaid especially, these are Medicaid funds that purchase the devices, and we build Medicaid for these devices. So that actually puts us in the situation of committing fraud. So then we have to go back and have Jolyn change these encounters and take these all off of there so that they don't get charged. But I still have to report to the Healthcare Authority because the devices have been used, but they haven't been used in appropriate individuals. And then in the right-hand column is all those that are over 19. And I can't do anything to change that. So just a reminder that these are the indications for CHIP. I have a whole lot of CHIP devices that we purchased because the funds were available. And then because of COVID, we haven't had as many clients coming in. So I have a lot of them to use, and I would appreciate your help in inserting them, but just to make sure that they're inserted in the correct clients. And then good news that we can share is that Mirena was just approved for 8 years. If you have not heard that yet, clients that have their devices that Mirena in can keep it for 8 years. And for those just getting it, they won't need to come back and see us for 8 years. Well, they need to come back and see us for a preventive health visit, but they can keep their device for 8 years now. Last year, they extended the effective time for Liletta to 6 years. Paragard is actually effective for 10 years, and don't give up hope. I haven't given up hope. I keep trying. We still don't have Paragard available, but I keep trying, and I'm not giving up. And then Nexplanon is effective for 3 years. I just wanted to remind you, like I've mentioned before, that one of the advantages we have as Title 10 clinics is that we do have the ability to insert IUDs and Nexplanon on the same day of service. So if we can reasonably rule out a pregnancy and balance the risk factors with the likelihood that the client will return, if we send them away today, and are they going to be able to come back in 2 weeks or whatever the time frame is? Just reasonably balance those risks. And also a reminder that condoms are a relatively reliable method of contraception, and they may be the only method that some of these clients are using. So if they report that they've used them every time, or they've used them on the most recent encounters that would put them at risk of pregnancy, we can go ahead and insert the devices at the day that they're in the clinic. Now, I realize that sometimes it's a real busy day when a client decides that they want to have an IUD or an Nexplanon, and so you have to have them return, even if you can rule out pregnancy. But I'm just asking that you think about that, and if you've got some people that haven't shown up that day, you've got a no-show rate that's higher that day or something, and you can potentially insert it that day, that would be fabulous. Skip that. Okay, like I mentioned before, a reminder on chest health. This is an e-intervention application for linking clients in need of substance use or behavioral health services with providers in your area. We did a training on this. We've done several trainings on this actually, but if you're new and you haven't been trained, or if you're in an area where you were trained but you haven't used the information and you need a refresher, just let me know, because Kim from Chest Health is willing to meet with anybody, any district or any group of people, or I think she's working on recording a training that we can just have available for people that need a refresher. Through this application, we can screen for the types of services that are needed and create a list of potential providers in your area for the clients that you have. And once the referrals are made then by staff, the client downloads the app. So the only bad thing is they have to have access to a smartphone in order for this to work. But after they download the app, then they can communicate directly with the referral provider, and the provider will contact them. It's not like when we give them a paper referral that they have to take with them and call some other provider and make an appointment. This is a warm handoff and to another provider, and then, like I said, the providers will contact them through the app. There's also educational peer support information that's available through the app, and this service is currently available to all family planning, maternity, and child health clients. And this is just a quick report. In the last year, we've had 19 referrals. They've come from region 4, 7, 9, and 10. That's why I said some of you may have been trained and just not had the chance to use it, and so you might have forgotten details about it. And the clients have been referred primarily for individual counseling, outpatient treatment, and initial assessment. And then you can see they also get perinatal and not perinatal medication-assisted therapy, outreach and engagement, and some unspecified reasons. Now I want to take just a moment to touch on options counseling, because I've received some questions recently about this. So options counseling is still required by federal statute. However, when Roe versus Wade was overturned with the Dobbs and Jackson decision, there were quite a few laws that became effective in Oklahoma that prevented us from talking about abortion services or providing abortion services or linking people to abortion services. And so we put out some guidance on what you could say, and that has not changed at this point. We did submit requested documentation to the Office of Population Affairs, which explains how our laws prevent us from totally meeting the federal requirements. So there is some discrepancy between the federal requirements and what we're doing right now. And we're all aware of this, and we've submitted the documentation explaining why we feel like we have to do what we have to do, and we have not heard anything back. I just actually heard back from our project officer just a little bit ago, and she said it's still under review. So for now, the statement remains the same, and you can say, in the state of Oklahoma, the only option for terminating a pregnancy is to protect the life of the expectant mother. As such, abortion is a medical diagnosis and a procedure which should be made in consultation with a licensed physician. Any additional information can be found on the HHS website. I'm also aware the HHS website, the general HHS website, does not give a lot of information. So we're working on that, but that's the extent of what we can say at the moment. Okay, moving on to comprehensive program reviews. Like I mentioned, we are restarting the comprehensive program reviews. If you're new and you have not been a part of these, MCH goes out and completes comprehensive, we call them comprehensive program reviews, because we review all programs that you're providing in your counties, which includes family planning, maternity, and child health. So we put these on hold during COVID, like I said, because nobody was providing these services and you weren't in the clinics, but we're restarting them again in District 9 in December. They'll be slightly different if you've participated in these before, because we're creating a Teams page, and a lot of the information that you copied off and put in the notebooks, I'm going to ask that you upload into the Teams page. In the past, I think you've copied the same material multiple times so that it was available at all of the county sites, and this will make it easier, so you can just upload it once into the Teams page, and then everyone will be able to see it in one place and review it, and you won't have to make multiple copies. So this is something new that we're piloting, and it's based on the model that the federal reviewers are doing with the grantees. So we'll see how it works, but this is what we're going to be trying. As I mentioned, OPA still requires us to observe family planning services being provided. So we don't want you to decrease the services that you're providing on the days that we come out. We want to see services as you usually provide them. If we happen to be in the way, we'll step out of the way or wait for you to be able to answer our questions or take time with us. But don't change your schedule for the days that we're in the clinics with you. And Title V and the Maternal Health Innovation Grant do not require us to actually observe services being provided. We would like to, of course, because you're doing great things. But if it doesn't work out scheduling wise, the priority is to observe family planning services and then learn about maternity and child health if we have to. Just a reminder on equipment, as things have changed over the course of the years and clinics have closed and opened, we found that some of our equipment was missing off of inventory. So this is just a reminder that MCH has purchased most of the microscopes. There's a few out there that were locally purchased, but most of them were purchased by MCH. The ultrasound machines and the probes that go along with them, the fetal Dopplers and the fetal monitors were all purchased by MCH. So if for some reason they need servicing or you don't need them anymore, then please contact us, but don't surplus them from the counties because they're ours. Oh, and Melissa, I mentioned this morning, and I forgot to mention this afternoon, that you got lucky to be the first, but the federal team is going to come visit us sometime in early 2023, in the spring of 2023. So at least D9 will be over, and you know that the federal reviewers will not be coming to your sites. I don't know who's up next and who will get lucky, but you guys, we go to who needs to be seen, and we don't go back and review with the federal reviewers the sites that were just completed. So okay, a quick reminder. Well, first of all, I wanted to tell you that if you didn't know, our Title X federal grant was reduced by $500,000 this year. And so one of the ways that you can help us with this reduction in funding, we tried very hard not to cut services anywhere or to cut contracts anywhere or anything. But one of the ways that you can help us out is with medications. So medications purchased with Title X funds should be issued to uninsured clients, clients requesting confidential services, and clients that cannot get to a pharmacy for some reason, just because they don't have transportation, or I know that in some of the rural areas, sometimes they don't carry emergency contraception. But this is what the Family Planning Manual says. And so I'm just reminding everyone that what you have in stock